It's my honor. My name is Daniel Eisenberg. I'm a faculty member here at the university in the School of Public Health, and my research focuses on college student mental health, and I'm part of the organizing committee for the conference. It's my honor to introduce our closing speaker, whom many of you know quite well, and you can see some of his roles up on the slide, the slide here. John Greden is the Rachel Upjohn Professor of Psychiatry and Clinical Neurosciences, the founder and executive director of the Comprehensive Depression Center, and he holds many other titles and has had many other accomplishments. He's published hundreds of articles in peer-reviewed journals. He's written and edited books. He's acquired many grants. He's mentored dozens and dozens of people who have gone on to prominent positions and many accomplishments in psychiatry and beyond. But more important than that, I think for many of us at Michigan and elsewhere, John is an inspiration, and in terms of what he's done as a leader and a convener. I think his style, as many of you know, is to bring people together, to bring ideas together in a very generous and open-minded way. And for me, I started my career at Michigan 15 years ago, right around the time that the Depression Center was getting started. And so it's been fortunate timing for me to just observe what John has built and how he's brought people together, and how he and his wife Renee as well have been so generous with their time and energy and their ideas, and so open-minded in terms of disciplines that they were bringing together people from public health like me, from all over campus. It's never been just about psychiatry or even just about the mental health field. So in so many ways, John is an example for us to follow, and has built a lot of what we've been talking about and discussing over the past couple of days. So I want to thank you, John, for all of that, and welcome you to the closing keynote. Thank you, John.
Thank you. That was terrific. I have the privilege of closing this out, and I also have the privilege of having Scott hook me up so that I can walk around. If I trouble you with that, shout at me, and then I'll go behind the podium. But this is an honor, and this is the 17th year that we have been doing this. And so I would like to tell you a story that builds upon the sequence that we've gone through over this last day and a half, and I think that all of us are going through. But in order to do it, I just thought, okay, I've gone to some of the sessions, and a lot of information has been disseminated, but I would like to try to give first an overview picture of what is the problem that we're talking about. Depression, anxiety, the way I listed it up here, they aren't the only problems. And then secondly, what have we learned that enables us to do this term that you have seen in the title, namely precision health or precision treatment, and I'll try to explain that. And then third, what can we do to really accelerate past the barriers that have now popped up, and I'll try to explain those to you. And the theme of this meeting this year was to say, let's talk about stepped care, or let's talk about strategies that get us past problems that we have. We haven't solved it yet. So, and I was just telling Daniel that one of the proposals that I wanted to throw at all of you, it's always tough giving the last one because people go catch planes and stuff, but I think we need to almost build upon what Daniel said I have no choice but to do because my genes make me do it. And that is to say, let's collaborate and figure out how we can mobilize on the accomplishments and push collectively from across the entire nation to have some sort of a campaign to now do some things. I'll explain all of that, but let's walk through some of this. So this is me. These are purported conflicts of interest. I'm on advisory boards. I have no conflict of interest for these. They're in your handouts, and you do have handouts, by the way. The agenda that I'm going to cover is just what I've summarized to you. You can see this up there, skim it real fast. It's an awful lot, a lot of information. The front end, because all of you have been going through these things for the past several days, or day and a half, really will go fast, but I want to do it anyway. And that's a brief overview. So let me give you a perspective. Why is there a depression center, just with the word meaning depression, bipolar illnesses, related disorders, etc.? Why did the University of Michigan decide to do that a long time ago? And I either get the credit or the blame, but it was a focus. And you can see why. So number one, common, really common. 1 of every 4 or 5 people in the world has these problems. 2, it starts young. 15 to 24 are ages of onset. 3, why the title of anxiety? And this one is sometimes provocative. When I was chair of our department, I ended up having a yen for doing subspecialty programs. We started a wonderful anxiety program, still exists. We had depression programs. We had programs that were substance abuse. We had, why? Because that's the way academia worked. In actuality, depression and anxiety, just to pick up these two, and bipolar illnesses, 50% of them start with depression, but depression and anxiety coexist. The smallest sample is 75%. And I used to say to our residents and medical students, when they would tell me, no, this is anxiety, not depression, and I used to say, okay, I'll tell you what, let's see this person together and we'll do an evaluation. And if at the end you say it's one and not the other, I buy lunch. And I've never bought a lunch. And so, because they coexist, they're common. And that tells us something about what do we do to treat them best. Then we end up having the fact that they get chronic if they're not treated. One of the things, if you started to say, then how do we overcome that? And this is the marketing campaign, the mission, if you will, for the Depression Center. 1, we need to find them earlier. That's self-evident if they start early, when they're more treatable. 2, we need to treat them better. That's research. 3, we need to not just get them well, but we need to maintain wellness. 4, to do any of that, we've got to overcome stigma. And I'm going to tell you a little story about that, which Daniel largely gets the credit for. And 5 is the University of Michigan should be bold enough to actually say, let's try to catalyze a national network that enables us to work together just like cancer has done. And that has become the National Network of Depression Centers. And so all of those patterns that essentially are there are the things that have been sort of done. But along the way, what we're studying, what we're learning, what we're trying to treat, what we're trying to prevent is tough. And we don't yet know how to give the right treatment for the multiple causes. And so the most difficult message I'm going to be giving you, I'll have another little game to explain this to you. I do it. Stephanie Abraham, who's wonderful, is sitting down here, and she's a communications star for us. She writes things, I write things, and then I send them around to various people. And I use the term depressions and bipolar illnesses, and people take off the S. They think I've actually misspelled it. And I do it intentionally because there is no single depression, period. And so in the sense of saying that, I was trying to say, let's change the world, let's educate them on this, and all I even do it was choosing the word. So the title of One Size Treatment Never Fits All really comes from the fact that if you have multiple causes, do you expect one treatment to work for everything? And I'm somebody, if you ask me what I do psychotherapeutically, it's CBT mostly. I learned it a long time ago. Medication, I'm a psychopharmacologist. Do I believe in some of the other things? Sure. And my major interest was treatment-resistant depression. I saw the people and evaluated them when there was largely failure to respond to anything. So with all of that, that's the big overview picture. Now, if we then, you haven't even seen all of that. I got to get with the slides here. So now it just comes up. Well, you can glance at that, but that's the little caption. One size will never fit all. And Now let's move it to college students. Look at that. I said it starts young. Look at that age of onset. Those are depressions. 15 to 24 are the peak ages. And there's all kinds of documentation for this. Let's look at the consequences. This is an old slide, but it's updated just even recently. That's Tom Enso, who was the keynote person last year at this conference and talked literally about mobile monitors. But he was the director of the National Institute of Mental Health. And I pulled this slide back out because he was a keynote speaker in 2004 for this conference. And that's not when this is from, this is later. But depression, clinical depression all by itself leads the World Health Organization categorizations for most disabling. This is an earlier version, 2017, it was number 1. It had passed heart disease for a brief period. It's tough, it's big, it's common, it's long-lasting unless it's treated. We've got to do better. And so now, let's start doing a little. I've now summarized some of what you've had for the past day and a half. Now let's look at college students. And there is this word stress. And it's a big one. So start walking through. What have you heard about, depending upon which session you've been in and hearing about stresses? I just made these up. So number 1, my studying feels overwhelming. I have a bad grade. I don't like the career direction that I'm in. I'm not going to make any money now that I've chosen it and I'm 2 years into it. What do I do now? I can't keep up. My classmates are smarter than me. I'm using substances because everybody else does. And I have a part-time job and I'm sleepy. And at this stage, my parents are just giving me a hard time. Can't stand my roommates. I've had some difficult sexual encounters. Stigma, I'm struggling, but I'm not going to tell anybody. And then these weird schedules. I've been trying to do other things, or drink myself to sleep on some of the nights. That just actually seems to be making things worse. And I was having fun with this, you could see it. Leaving home, I miss my bedroom. So everybody else can drink more than I can, and they tease me about it. I no longer have my doctor. I had problems at home. Somebody toss out a figure, how many people do you think arrive on this campus, and I would guess it's comparable for all of yours, with medications that they're taking coming from home in their first year? Good guess? Toss one out. 15. So think of the number of kids that are walking onto campus taking meds. What happens if they're from Ann Arbor? They could go see somebody. That's just not the case. What happens if they're from Colorado, somewhere else? And that needs a transition, a shift. All of those things are stresses. I get teased, stigma. Classmates, too liberal or too conservative. Politics are part of everything. My girlfriend or boyfriend went to a different school. There's no privacy. So then you start saying those figures that I gave you earlier, are they the same on college campuses? Yeah, 1 of every 5. Suicide is the second leading cause of death. Depression is the most common underlying cause of suicide, about 70 to 75%. And sleep problems coexist everywhere. And there was a wonderful session yesterday by Roxanne Pritchard, if I'm getting her pronunciation right. How many of you happened to be there? Raise some hands if you were. I was. It was terrific. You ought to invite her to, she's in your handout, but she talked about the various problems that people have. And I thought, we have a sleep lab in our depression center and Department of Psychiatry. And this was one of the better sleep talks that I heard, and I know something about it. So it's there, and it's a big deal. So are we the only ones, our students, and the clinicians struggle? Let's look at college administrators. The costs are huge, but we're not covering it. We're not really solving this. We talk about the need for early screenings. How do you do it? People struggle with confidentiality. That's the stigma story again. Stigma fighting, not easy. Clinical specialties, and this is of relevance to great talk that Peter gave, and the whole sense of what do we do about step care, and one size treatment doesn't fit all. How would we address multitudes of treatment skills when we have clinical psychology here, social work here, psychiatry over here? I mean, our systems are set up in a difficult way, and we have student health, but then they refer out. And as a quick digression, I'm going to just tell you the story that existed when we started this. The reason the first Depression on College Campus conference was held is that the then director of the Student Health Service here, Bob Winfield, who happened to be the primary care doc for my wife and I, and me, and so he was a friend and a doc. And interestingly, we had a suicide on campus. It wasn't on campus, it was of a student here. And essentially, the mother got very upset because she had been to 5 different locations. And there was no exchange of information between any of the 5. And I ended up hearing about this indirectly. And I talked with Bob, Dr. Winfield, and said, why don't we hold a conference? Ended up hooking up with Todd and various other peoples, and we gathered together and sort of said, let's do this just to find out what other campuses are doing, bring people together. And in the process, we found not only this person, but that was the norm for everybody. So we don't talk with each other very well, even though people are scattered. That's changing a little bit with electronic health records, but not very rapidly, and that's 17 years ago now. So the question then becomes, what else are the troubles that administrators face? Man, when a suicide impacts a campus, it's tragic. And that's what we did at our lunch today. If it's a student, everybody suffers. And it really is difficult. And yet, you saw they're the second leading cause. Accidents are first, by the way. Second leading cause of death among a population of people that are not supposed to be dying is suicide. So how do we manage to do things? Well, everybody does work, and we find out that exercise is good, and nutrition is good, sleep is pretty important, but we don't adopt it. That came out in the sleep talk. Everybody knows what they should be doing, but nobody's doing it. So I'm trying intentionally to almost say, man, have we learned a lot? But we have real struggles yet in applying it. And sometimes I hear, by the way, I learned a lot about step care and about the shifting, and I'm kind of adopted. I told Todd, ooh, the world is here now, it's changed. We've got to do something about this. There are things I don't like if it becomes rigid and formulaic. But I think the idea being that we cannot treat everybody, I'm going to share information. Basically, our CAPS program, Todd, if I get the numbers wrong, correct me, but I heard today that 120 to 150 new students a week are seeking help here at Michigan. How do you manage going to CAPS? How do you handle things like that? Not everybody can get plugged into the one-size treatment that we gave 40 years ago. It was a traditional, different kind of treatment. And it doesn't work. There just aren't people. And then sometimes people get into struggles in our own world, our world of mental health delivery people, and we just need to be frank and forthright with each other. Some of us lock into, I'm a therapist, I'm a psychopharmacologist, I'm somebody who believes in mindfulness, and I don't even like some of the therapies that are being done. Well, I think that all of these things are overdone, on and on, and we sort of know that that's there. Somewhere we've got to take it on a little bit. And this phrase that's up there, I'm giving you a somewhat sarcastic approach. It's clear that, see if I can remember how to do this. Environment and stresses are critical. I gave you those front-end stresses. It's also clear that they work through our genes, and they work on structures, and they work on systems. And we give labels to those systems, and then that's when we split. People who are struggling have something going on in their life and in their environment, and the brains are involved in that, and everything else that they're doing, drugs, smoking, marijuana, cannabis, it's all there. Over here, we start separating, and we categorize them. And I've never been too much of a fan of DSM. I tell our residents they need to learn it, just simply to pass, or medical students. But after that, they should get rid of it. Why? Because it gives diagnoses and labels, and that's what people respond to with stigma. And there are euphemisms. Oh, you're wacky, you know, kids pick them up, you're psycho. That's part of the stigma story. So, but this is real, and this is where we're at right now with this. So, and then let's just giving you this quick summary of what's been kind of there. The suicide story, I just said it to you. Second highest cause of death. 2015 was the highest year. How can we be learning so much more, but seemingly going in the wrong direction on suicide? And I'll try and give you an answer for that. Some of this is the opioid story. Some of it is guns. Nobody likes it when we say that, but it's there. And if we have to address these scenes, like, where am I? Like that, backpacks for those who have died on campuses. It's sad, it calls attention. We had a lunch today that really was terrific. I mean, family helping to support student advocacy makes a difference, but we've got to do something about that and that. And so all of those, all that I've done now is just summarize this. And warning signs, this is in your handout. They're there and they're written about, and I'm not going to spend much time on it, but we get these warning signs. What we're struggling with, and what is the theme of this conference, is how can we have the care delivery that almost has to occur on campuses, because that's where people come and live and stuff. How can we then mobilize that system to make it work better than what it is right now? And all of these things are the warning signs that are there, but it doesn't fit well on campus unless something else comes. And I'm going to get this in the closing thing. Who lives with these students? They're roommates. You know, so we have to be involving peers. Who talks to them? Are they calling home all the time and saying, Mom, I have thoughts of not wanting to go on living? So those signs that are up there are going to come through other channels. That gets to be a public health approach, peer-to-peer, all of the things that I think we all ought to be doing, and that's got to be part of a stepped care approach. It's got to be part of the package. And these are, again, prevention steps for suicide. I'm throwing them in there just because it's the most troublesome of kind of what we do. But enough said on it, it's a big thing. So the theme of my talk is the time is now. I wish we had something when we say, why was one-size treatment? Well, what's going to be there? My answer now for about the past 7-8 years would be precision treatments. What's the analogy for that? So at one time, for those of you, the Emperor's Malady cancer book, it ends up being a story about how at one point people who got cancer, what were they treated with? They were blistered with chemotherapy agents, radiation, chemotherapy. I mean, we're going to kill every cell, and the cancer ones grow faster, so we get them better or something. That was pretty brutal. And now it's at the point where if you get into your cancer worlds, they don't talk breast cancer or lung cancer right now. They'll give it a number, a code. They've got them broken down, and this one responds to this treatment, but not to those three. That's precision treatment, and we'll come back to it. We struggle with that, but step care and other kinds of things maybe can help us get there. And so why will one-size treatment never fit all? And I've used the next several slides in teaching medical students and residents And boy, is it hard. This now gets to the word depressions and bipolar illnesses. So this is a list of why one size will never fit all. I'm giving it to you in the sense of this is stressors differ. So that diagram I showed you on the front end, they're not all the same. If I'm abused sexually at age 4, it's going to be a different consequence than if I've basically lost a parent at age 4. And that's different than if I'm getting PTSD from Iraq or Afghanistan. All of those work through mechanisms, but there are clinical evidence that it's different consequences and different treatments may be required. Traumatic brain, traditional brains, genetic neurotransmitter alterations. What these are now, some of us really are struggling with genetic differences. And we have propensity. If somebody has a parent who has bipolar illness, the odds of bipolar illness go up considerably if you're that child. If somebody has an identical twin who has bipolar illness, identical twin, the odds are 70 to 80% that that person is at risk. Genes are involved. We have to recognize this, and we all know it. It's just that we don't all factor it in. Are genes also going to be involved in the treatments that we select, the so-called precision treatments? You bet. Just like cancer and cardiovascular, they're going to be there. And we can master these things. This listing here shows all kinds of medications. It's really kind of exciting now just to give you a commentary for any of the clinicians in the room, the ones who really care. We have had very poor results for history in treating people with postpartum depression, women who really got severe postpartum depressions following the birth of a baby. And it's been hard to treat. It's got high suicide rates. Sometimes it has the infanticide. And we haven't done very well with it. And all of a sudden, in a way almost patterned after the ketamine story that you may read about, there is a push now to investigate a whole new category of medications, and I'm kind of giving you what I think is hopefully an early prediction. I think the FDA is fast-tracking a review, and I think we'll see a new product come out probably in about 3-4 months that will end up having it got held up because they thought they could just do this in doctor's offices, but you have to give it IV. But it has a very dramatic response. We got to learn it. Then we've got to learn to pick it out. How are we going to sort? Well, you need this treatment, because those are life-saving types of things. I'll talk about the pain one a little bit later, and we'll talk about some of these things because they all can produce problems with depression. So I'm going to give you one quick clinical anecdote of mine. Not personal, but being a clinician. I was seeing a person who was referred from Ohio, wanted to be evaluated for treatment-resistant depression, had not responded. And this was somebody who had first done very well and had been on the same antidepressant and was stable for about 30 years. And then all of a sudden started to struggle. And there was kind of an issue of what's next and what do we do. And when I saw her, generally I ask sort of an array of questions, but this one was a little rambling and we didn't get everything covered that I usually even ask about. What happened is at some stage in this, I was assuming that the medication that she had been on wasn't working, stopped working, if you will, and we needed to switch. And I was already thinking in my head, what's going to be next and what else? And, and at some point in time, this was somebody from Ohio, and I said, what are your plans? When are you going home? And she said, well, a friend came up here with me. She was concerned about me. Drove up, and it was kind of funny. This is her. We were in the hotel last night, and this morning we got up and we met for breakfast. We both in the bathroom. We shared a room to cut costs, and she said, I asked my friend, well, so how are you? And she said, "I'm terrible." She said, "Has anybody ever told you, you snore so loudly, I couldn't sleep all night long. I literally couldn't. You didn't even wake up when the guy in the adjacent hotel room was pounding on the wall, trying to wake us up. And my gosh, you got a problem." She's telling me this. Did I ask about the sleep apnea? No, I hadn't on that particular one. I often do. But in a strange way, instantly I thought, she needs a sleep lab assessment, not necessarily just a prompt change of medication or referring her back to a different psychotherapist, which she had back in Ohio. All right, so everything shifted. We did it. She had the results, came back, I got them. One of the more severe sleep apneas that we've seen, this kind of stuff, she was treated with a CPAP machine. Suddenly, her depression went away again, and she was back to where she was before. That's precision treatment. It was dealing with something that was there. All of these are sort of listings that kind of are other things that can cause depressions. They're on there just for examples for us, but I think at some stage what we want to do is keep our focus on college students and ask how can all of us work together collectively across campuses and bring some ideas, including like step care, and put them together into a program where we can become a collective voice, not just voices to each other about what can be done on each campus, but to move it on. Okay, these are some more. Clinical depressions also can emerge from every one of those things. And if you started to ask, tryptophan deficiency, that can be dietary sometimes. Our athletes struggle. Soccer players, cheerleaders, football players, hockey players, head injuries cause depression. The phenotype looks the same for clinicians, and it's often difficult to treat. They're not going to necessarily get better with an antidepressant in the way that we would deal with the other things. So glance at the list, and you can kind of see a story developing, which is how do we manage to do these things? So, and this list is incomplete. I mean, there are others. I'm just trying to point it out as illustrations. This is a list of the available treatments, and it's by no means complete. I got bored with writing them down after a while. I mean, I started just making this list while I was typing. And those are treatments. These are therapies, sort of. There are strategies that are in a book that I wrote along with several of my colleagues. And it was on treatment-resistant depression. I look at them now, and it's walking through, well, this didn't work, so therefore go on to this. And this was 2011, and I'm thinking, gosh, my own thinking was a bit flawed, just even at that point, because what you end up having is that didn't work shift. More than likely, what was the matter is the thing that would come from some of those earlier causes, sleep apnea, head injury, thyroid illness, sexual abuse by a spouse, whatever it might be. Those are different causes. They need different treatments. One-size treatment will never fit all. So with all of that, then you end up facing, it's a myth to believe what we do now really works that well. So the caption says, of course you feel great. These things are loaded with antidepressants. It's an old cartoon. The data are scary for people like me who have dealt with treatment-resistant depression. And you end up actually saying, how well do our traditional antidepressant medication treatments work? And this is the story. So all of you people now, sorry for this, you've all got major depressive disorder. And you go in and you get treated by good people with a standard antidepressant. These are the STAR-D data, which was the largest study of its kind done. Well, 38% of you get better. That's all. And that's after 4 months. 38%. So, and we're trying to get 100%. So we move you on to something. We add, we augment, we double doses, we double up the treatments. These are all described in there. And they're all done by our traditional, conventional approaches, Well, okay, so another little clunk gets better. That's not so bad, 30% of those who hadn't responded. But the total now is still sitting there. Oops, sorry. Going backwards. The total now we're up to 60%. Now it gets really hard. Now all of a sudden we throw in harder things and more hard things. And when we're finished, 1 year later, after a year of misery for that group in the red, you still are in depression. You know, what can we do that's different? And I'm just suggesting, I wish I had the answer. I'm not that good. What I really think we need to be doing is we need to have better approaches to figuring out, might we not be treating the thing that we think we're treating? And that's the one size will never fit all. So with those things, what about taking it back to college campuses? And these are the barriers on college campuses. Some of them are the same, but some of them were those special things. But think about what our students face now, even if we could catch them early. I don't really know where to go. How do I get, when we had some discussions, Todd was in this, we were meeting with our president. The Depression Center actually sits some miles away. And people said, how will they get there? You know, and it got to be a, you know, where do you put your clinical programs? This is something I'll come back to, but at one time we didn't have a waiting list. Right now, for reasons that are kind of good things, the waiting list is huge. It can get to be 5-6 weeks, and people call in and say they're sort of desperate. 5-6 weeks. You know, this is a problem. And what I was listening to in all of the conference stuff today is those were the same. And 15%, that figure, how do I renew my prescriptions? Where do I go? And is this something that really is there? These are, you all know these are the list. Peter talked about them, Tom was talking about them in various time points. We have struggles with this whole thing. I think we need a special program that sort of deals with something, and we have an ideal laboratory to pull this off. And I'll think it's coming now, but it's this one, and this is the stuff that Daniel and team sort of have been doing. One of the big barriers is all of a sudden become a triumph and a little bit of its own little mini tragedy. Daniel Eisenberg, Sarah Lipson, and a number of others have been doing what is the Healthy Mind Study for some time. And see if I get it close now. You gave me updates, but it's 10 years with similar questions and trying to do it, and it's now closing in on 200,000 students and probably close to several hundred campuses, right? He's nodding his head up and down. And that means that we've got a really large database, as they do. And if you started to ask various array of questions, similar ones, that characterize you have stigma about yourself, you don't even want to hang around with people who have these illnesses, these mental illnesses, it would scare you. Would you be willing to ever consider going to get treatment if you needed it? Have you actually done that? You know, those kinds of questions, and then watching the trend. And what are we seeing? We're decreasing stigma a lot. You know, somebody asked me one day, how are you going to handle stigma? And I said, we're killing stigma. We're actually beating the hell out of it right now. But that's becoming two things. One, that's on college campuses. I don't think the whole same thing holds true totally in our society yet, but even there, you got movie stars and athletes. We're doing a very good job on this, and we should be kind of proud of it. But simultaneously, when you say, are you willing, and have you actually gone to do something? So now, 95% of counseling centers are saying we're getting higher demand. 88% an increase of student treatment. And the rates of treatment and diagnosis are going up. You know, now, instead of saying, no, I'm not sure I would go, we're seeing a third of the people who say, I have been there. Is that close? And so what we've done is we've managed to really work hard at destigmatizing and making these things into conditions that are stress-related and treatable, and we're flooding the system. That's what I think we ought to collectively sit back and say, how could we take it on? We need some help to do this. College presidents aren't in a situation where they can just say, I can afford this. You know, we're going to do this. It's going to take an initiative that's a little bit like some special effort. So precision treatments, the right treatment, right person, right time, right dose, right duration. And those are, I think, now things that I don't care where they are, because sometimes this is now something where I'll give you my read on the data. If somebody has a severe depression and you can't find the other things that might be causing it, like that sleep apnea story I gave you, then, interestingly, the best data for the traditional depression is if you're severe, you probably need medications. You also should have psychotherapy. The best results almost always come when combinations exist. If not, you don't need that, but we have to sort that out in a way of actually having time durations, and that's the step care and other kinds of things. And all of these things, it used to be that we paid attention to this, and maybe this. We're going to have to factor in more strongly than what we do now, those items that are up there. And they are going to have to be delivered to students, and I was giving you all of the barriers in accomplishing that. And how do we do that? Well, we screen. We essentially strive to collect. Somebody help me, what time is it? Okay, so we got to start thinking about closing. We try to strive to collect, whoops, back up, the most precise treatments. And another little anecdote from me, now this is mine, but the data support it, and you'll have to just trust on that. If somebody comes in, and I used to fight this all the time in our clinics, they have depression, they also have alcohol. Well, you got to treat the alcohol, and the depression might go away. And if they happen to see the depression person first, well, let's treat your depression, and then maybe your drinking will stop. We should almost always be treating all of the problems that we feel we have treatments for at the time when they're actually happening. And it would be nice if we had better laboratory tests. That's not the focus of this conference. We also should, I think, probably do it as hard as it is to back away from, I like my treatments. I like some of the ones I do. You know, I'm not that good in some psychotherapies. I learned a couple, and I try to use those. But they're my preferred treatments. Maybe some people don't have them. This is what Peter was talking about. We've got to find out what people actually seemingly would do best with and prefer. And the time is going to quickly come soon, and I kind of know that I'm talking at a level up here and maybe a little bit dreaming of a future, but it's there, when essentially we're going to be saying machine learning and artificial intelligence and some of the features that come from pooling all of these data are going to help guide us in choosing some of this. And that's going to be good. The monitoring is important. I want to close with talking about a few things. The day has come now. I saw somebody yesterday. I have one, by the way. It's my holiday gift. I have yet to activate it. I've got an Apple IV watch. And it can be used to monitor. And I think we now are sort of actually watching just an explosion of how do we manage to have measurement-based care. You're going to wear it on your wrist if you want to. And we probably ought to be including these as strategies in everything that we do. These are things that can be done just in measurement. We can do those scales. This is actually now happening at Michigan, MIPACT, Michigan Predictive Activity and Clinical Trajectories. We've got 1,000, that's small. There are going to be many more to come. I sort of like this cartoon, you know, and it's basically, we're going to be keeping track of things this way, and we should probably start now. And we could get college students to help shape the rest of the world and even the rest of clinicians. And now I'm going to just tell you something very quickly, just very rapidly. Suddenly, we're closing in on being able to do a smidgen of what cancer has. We're using pharmacogenomics right now, and there'll be a study that's come from our depression center in conjunction with 14 other ones around the country that are sitting there saying, okay, we can take pharmacology, what we know about drugs, and how they're metabolized, hook them up with genes, my genes, if need be, and we can come up with a field called pharmacogenomics. It's being used in a lot of other fields. And we could take also pharmacodynamics. What do we know about my genetic structure? Well, now you have to measure that. And we can put it together with what we know about how changes in the body affect a drug, and we can look at some patterns. And the patterns turn out to be somewhat predictive. So some companies do this. There are now 5 products out, and you can take my genes, doing it with a little cheek swab, drop it in an envelope, send it off. A day and a half later, it's back. The doc gets it, and you end up having some genetic structure that comes from a formula, and this irritates doctors. They don't like to share it. They basically end up saying, that's proprietary. And right away, it's also marketing, but we're stuck with it. And something comes up then. And the something is, this is a male who can have certain medications, and and you guys can't see these back there, but it's basically, looking at Zoloft and Celexa and Prozac and this kind of stuff, and trying to be cheating and making it quick. The red is you need to stay away from that with this person because of their genetic structure and how they metabolize. The yellow is you could get by with it, but you better be ready to adjust doses. And the green is, this one looks okay. We don't know that it'll work, but it's okay at least to use, and it might be a safe start if you're going to use an antidepressant. This happens to be, if you look back on this one, this person had all kinds of warning signs of red. This person, had 1, so big difference in the genes. And so what we know now is if you then started to say the people, if they're getting one of those medicines in red, they don't do so well. And that data is now out there. And then if you switched them into one of the yellow or green, they have more improvement. They have more response, and they have more remission. And these are people with treatment-resistant depression. The first one happens to be me. Second one is my wife. She's given me permission to do this. We're very different. And when I've given this talk to doctors, one of the guys raised his hand and he said, "What the hell do your kids look like?" And I don't know. We haven't done that. But I think this is going to be something that we are doing in the future. We're going to probably be making some choices that are guided in helping these things. We've got an awful lot of work to do. That's the research piece. But our responsibility is to learn it. And what better place to start using it than on college campuses? So we ought to have 100 campuses that just sort of mobilize and do some things like this. And it's going to be, I think, clinically important. So these I threw in there just because they're in your handouts, and I've already alluded to a couple. But sleep apnea, chronobiology. I heard again this excellent talk on sleep. What do college students do? This is one that everybody should sort of look like. If you end up having, you go off in September, and you get there, suddenly I realize I can go off and drink and go to a fraternity recruitment things, and on Friday night you drink a lot and you go to bed at 2:30 and you sleep in till 1 o'clock. And on Saturday night you do the same thing. And on Sunday night, maybe the same thing, well, probably a little less likely. The net result is you miss the morning class. By the time you get to October or November, you are really botched up, because every one of those things, when you're doing a shift of 3-4 hours, it's like flying to Europe every weekend. And that's chronobiological phase shifting. And it's even got a syndrome. It's actually called delayed sleep phase insomnia. What's its major feature? Depression. And so we're going to probably have to start doing sleep scales on everybody. They'll probably even be in watches and stuff like that. It's going to be good to use them. The head trauma ought to be a part of just history. Recent infections. This is the sleep apnea story. It's common, and it's there. But all of those things probably can essentially have stuff that we put together. By the way, just take it home with you. It's in your handout. But the little thing of the stop bang, that comes from Ohio State. Those of us at Michigan can get by with that. That's a scale that was developed. If you snore, if you're tired, if you're observed to stop breathing, and you got blood pressure problems, odds are you can take the other things that are just measured, but even with that, odds are you probably have sleep apnea, especially with that O, if you're observed to have stopped breathing. And if students and roommates say that, that needs to be evaluated and treated. And it does work. This isn't a college campus. We hope not. I don't know. But those are things that actually are going to be worked in, I think, to how we do evaluations and treatments for our college students. And we can pull this off. The SAD story. I want to close with just this. Basically, the opioids and depression are killing us, and that's not a cliche craze. They are killing us. We're now dying 70,000 people a year, 45,000 homicides in America. And a lot of those are coming from this drug abuse epidemic that literally comes from trying to do something good with pain, but it wasn't a good thing. And if people have pain, the odds of depression go up. When they're treated now with the conventional approach that existed for about a decade, well, let's use opioids, OxyContin, oxycodone, tramadol. Those have turned out to be really difficult. The longer you're on an opioid, the more likely one is depressed. So with all of this, we're going to have a nice future, but not if we keep watching trend lines like that. That's the death rate in America right now. And a lot of that is from opioids, from those things, from overdoses. And that's actually what might be the passive suicide part of this. People who are using these for months, years, and then at some point, the addiction problem is even worse, and they don't really care. And so with this, there are many other things. These are in your handouts. People can get depressed from inflammation when we have epidemics on campus. You can get depressed from getting the flu, so get flu shots. You can essentially have markers for those things. These are all going to come. And what we all should be doing is, what's the best way to kind of keep track of this? They don't have a mother in their dorm, but they do have roommates in most cases. And what's been done by the group in our depression center, which we're really very pleased with, we've just received this American Psychiatric Association Gold Medal Award for this, is to train students in actually knowing what language you use, to use the right language, to ask the questions, to sort of pick up on this, and to basically, dude, what's going on with you? You don't look very well. What time is it, Stephanie? Okay. Anyway, that is maybe the thing that excites me most, and it's partially something that we ought to be just plugging in everywhere. The peer-to-peer approach has been shown to be very helpful among military people, and it kind of got adopted. You can move it into colleges, it works. We've moved it into high school, it works. And now we're trying to do it in grade schools. Many others, schools are doing similar things. But is it adoptable? This is something that comes from our group again. Basically, Elizabeth Cushman started a TRAILS program, Transforming Research into Action to Improve Lives of Students. That's Ann Arbor. Then another county asked. A year later, a bunch of others. This is 2018 now, and we've now moved this elsewhere. People are recognizing that we can essentially create a public health system. That's an approach to say, how do we manage to do this now? To pick up on guidance and to actually have people mobilize. I got your back. You know, the students do it. They have it with each other. And this can be done. If we're going to build websites, let's tailor them. Our team has done this in Wyoming, where basically people said, well, you're telling me how to handle depression. I can find it anywhere. I can go to, a website. What I want to know is, where do I go here? Every campus ought to have a tailored website, and these could be plugged in. In Wyoming, they were worried about their suicide rate. When you actually told people where to go, they gravitated to it. And people ought to pick back up on the conventional things. When people have rings under their eyes, it's a bad sign, even if it is exam time. Students will be picking up those things, listening to voices, watching the faces, looking at the signs that are sort of associated with depression. All of that's going to lead to a different future where we restore the whole interest in the conventional clinical approaches, but couple them with the new modalities, the new kinds of stuff that are going to be potential lab tests. And that's going to take collaborations. This is an illustration of the National Network of Depression Centers. There now are 26 places. But think of what would happen if we could do the same thing with college campuses. Think of how many college campuses exist that could become laboratories for trying to figure out what are the best approaches for step care or for anything else. And that's actually sort of the appeal that I'm making. So we'll skip over that slide, but actually just one more suggestion, which is not to, the little story up there is actually something I just heard on NPR not too long ago, and it was Big Bird. The appeal was for somebody who said we should use conventional language that's accurate and not try to deal with stigma by hiding it in different words. And the illustration that was being talked about was people dying. And they said, let's hook up with Sesame Street. Big Bird had a gift and he brought it to the store and he wanted to give it to Mr. Hooper. And he got there and he said, where's Mr. Hooper? I have this, I want to give it to him. Oh, Big Bird, we told you Mr. Hooper has died. Oh, okay, I'll come back tomorrow. And, we end up doing things. We put your dog to sleep. And kids, when they're 5 years old, start saying, what happens if I go to sleep? Grandpa passing away. I think when it comes to depression and anxiety disorders, we've got to call them that. And I don't like the term burnout right now, just to sort of give it to you. That's a personal thing. But I think we slide into terms thinking that we can change stigma by changing words. It doesn't really work. And what we really have to do is change stigma and give hope by giving data. So all of us, if we abandoned our superiority, my treatments work better. No one-size treatment, mine don't. If I'm very good at giving one, that doesn't mean for everybody. And we ought to be willing to share and partner. And, the social media story is one that's real. But I sort of was pulling some of these together even when I was seeing the topic areas from this meeting. And I think in total, this one especially disturbed me when I found out, actually it came from Deborah, my assistant, and she said, have you kept up with Momo? And I hadn't, but I learned. And we got stuff out on our web right now that can be feeding into all of this, and it's pretty dangerous. And one of the things we ought to think about is privacy rules. We have them on campus, but if we take parents out of the story, we're actually depriving something. You know, not only do you go away from home, but we take them out of the care and delivery, and I think that sometimes is problematic. I don't know that I have the answer to it, but I think we ought to be reviewing these things on every campus and on how we actually monitor and oversee. And I don't like rigid, we're not going to permit you to watch this, but we can educate. We're seeing that with the P2P, the peer-to-peer. It works to talk to students. And so with all of that, some goals. If we formed a group, if we could collectively bring campuses together, and we said, let's reduce our suicide rate 20% instead of having it sneak up. Let's get rid of treatment resistant. Let's get a registry that we start sharing. Let's come up with biomarkers, and let's do maintenance treatment and keep people well when that gets them better. And let's talk about 5-year wellness. Cancer does this. We treat people for weeks, and then we stop. And they slide back in if they really do have these things. So with all of that, let's get out there and spread the word. And I intentionally, when I was doing this, was thinking, okay, I'm going to see all of these great talks, and I tried to see as many as I could. The wisdom collectively from the people who come to these meetings is really impressive. How do we put it all together and come up with a new campaign? The Depression on College Campus started to educate and to share. I think now we've got to move it into a public health campaign, and let's do it together. So with that, I will thank you. And I think I see Stephanie running around back there, and I would like to do something real fast. She's the one who really, Stephanie Salazar and her team, if she can still hear it, and I don't know whether she's there, let's thank her. And I think I've done a bad thing that speakers are never supposed to do, which is go beyond time. But I'll tell you what, I will stick around, and I'll turn off this mic, and I'll walk outside, and then we can field some questions, because I think it's 4, isn't it? Past, right? Yeah. So ladies and gentlemen, thank you so much. Come back next year and bring things with you. So.